Hello dear students, this is Dr. Meenakshi Sundaram A discussing the INI-CET recalls from November 2024. I welcome you all to the discussion. All the very best for your upcoming results. All the very best for the upcoming NEET PG exam also. And whatever happens with INI-CET exams, please keep studying. Whatever that you had prepared, just increase the amount of hours and the dedication that you have always given for the INI-CET exams, because the bigger exam would be NEET PG 2025. Now at this point of time, let me tell you, this year's microbiology question paper has been simpler and it is moderately okay. When it comes to biochemistry question paper, more than clinical questions, the laboratory-based questions have increased. So on this aspect, pure straightforward microbiology questions have been 12 to 13, while connected questions towards other subjects in the form of infectious medicine has been another 15 to 16. So totally we'll be discussing 31 questions, and I will make sure that you will be able to use this information for the upcoming NEET PG exam also. Now let's begin with the first slide here. All the MCQs are as recalled by various students, and the credits will be going to the respective owners for the images and sources. Now, the first question, male patients with urethritis, which is the least likely cause? They have given you 4 options, out of which the 4th option is not available at this point of time, but it is not necessary, because among the 3 options given here, I can easily suggest that Gardnerella vaginalis does not actually play a role here. Why? Because they have mentioned one thing very clearly, the patient is a male, and Gardnerella vaginalis previously referred to as Haemophilus vaginalis. This organism is known for causing bacterial vaginosis, which can give you ammoniacal smell through the vaginal area, and this is known to attack the vagina of the females only. So they have not much of a role to play in case of male infections. They don't cause urethritis in males also. Then now you can ask a question, then what about Trichomonas vaginalis? This is capable of attacking vagina. Yes, Trichomonas vaginalis is an STD infection, that is sexually transmitted disease infection. At the same time, it can also be fomite transferred, that is using clothings. Now, this Trichomonas vaginalis is known for attacking both males and females. And in case of females, vaginitis and urethritis can happen. In case of males, it is capable of causing urethritis. And apart from that of urethritis, this organism is also capable of irritating your local GUT, and this is known for causing clear whitish discharge from the urethral specimen. I speak about Trichomonas vaginalis. When it attacks the males, it is capable of causing clear whitish discharge. Apart from that, it is also known for causing prostatitis and epididymitis, apart from urethritis, which we discussed just now. Here, when urethritis happens, it is capable of causing dysuria, which is painful urination. Sometimes it may be burning micturition, but burning micturition is purely a property of gonococcal infection. So if at all they speak about burning micturition to be the most important concept, you speak about gonococcus in case of males. But mild burning micturition, but definite dysuria, you can speak about Trichomonas vaginalis. So B and C, both are capable of attacking males and females. Now, what is the information that you have to know about the gonococcal infection? See, when it comes to gonococcus, it can attack both males and females, but the beauty is males will be more than 90% symptomatic. And here in case of females, most of them are asymptomatic. How will you make a diagnosis in case of gonorrhea in case of females? It is a serendipitous discovery, an accidental discovery. And if you want to make a diagnosis, you have to go for swab and culture, because clinical features are very less in case of female gonorrhea. But in case of male gonorrhea, clumps of pus can actually come through the urine, so pyuria can be seen, dysuria can be seen, and burning micturition can be noticed. So gonorrhea is very symptomatic in case of males, and it is almost asymptomatic in case of females. When it comes to Trichomonas vaginalis, it can be symptomatic in both males and females. So Gardnerella vaginalis is not known for attacking males. That is why in case of question number 1, the best answer would be Gardnerella varicella vaginalis. Now let's go for the next question. Now look at this, it's a logical question. Which vaccine is not indicated above 65 years of age? See, you might be confused about the clinical notation behind this age of 65 years. Why this age is important? Because most of the infections are known to be dangerous for people in the extremes of age group. What do you mean by extremes of age group? Either children who are less than 3 years of age or adults who are more than 65 years of age. Why less than 3 years of age are actually extremes of age group? Because they are susceptible to infections and they can actually be deadly infections for them because immune system is not yet mature. Immunity's maturity is lesser in case of children less than 3 years. Children more than 3 years can actually claim to have very properly matured immune system. Now, when it is more than 65 years, it's not about the maturity, it's about the waning off of the immune status. The immune status slowly starts falling. That is why mortality and morbidity will be very high in people less than 3 years of age and more than 65 years of age. At this point of time, you have to support these people by having vaccination. But the problem in case of less than 3 years of age is that the immune system is not mature. So when you give polysaccharide vaccines are very weak antigens. Remember, they are very weak antigens. So your immune system is so weak and immature, it won't be able to handle a very weak antigen. A very strong immune response is the one who is capable of identifying even a weak antigen. Now, if at all you have an immature kind of immunity, then it can identify only strong antigens. The alarm is very loud. That is why they are capable of hearing it. But only a strong immune system is capable of identifying even a very weak antigen. So when you try to give polysaccharide vaccines, you go for conjugate vaccines. Example, pneumococcal polysaccharide vaccine. This is a conjugation of the polysaccharide antigen so that it can be understood very better by the children less than 3 years of age. So when a person is more than 65 years of age, you are supposed to support his immune system by giving vaccination. But on that basis, which vaccine among the four is not given for elderly people? The answer has to be HPV. HPV is generally given for youngsters who are sexually active and who have multiple sexual partners. Now here comes a question. You may be asking, do you say that the 65 years and above people don't have a sexual intercourse? It's not about that. When a person is a youngster and he has become sexually active in a very earlier stage of his life, then he has a very long life ahead of him where he will be continuously sexually active and he may have multiple partners. But for a person more than 65 years, the number of years available for him to be sexually exposed to multiple partners is lesser. At this point of time, HPV vaccine may not actually be recommended for people who are older. But when it comes to influenza vaccine, varicella vaccine and hepatitis vaccine, you can try it for people more than 65 years. Now, hepatitis is also given for people who are in the younger age group, but HPV is definitely for the younger age group. For this question, the best answer would be HPV followed by hepatitis. But influenza vaccine is capable of giving proper support not only for the older people but for any people of any age group, because the vaccine strains may not be able to tackle the older vaccine strains, may not be able to tackle newer strains who are coming as wild infectious agents. So whenever there is a strain change in the community or in the society across the globe, you need newer and newer antigens and vaccines to support people. So influenza vaccine and varicella vaccine are definitely important in case of people who are more than 65 years. What about varicella? Varicella zoster. If at all you have a varicella zoster virus attacking a person for the first time after 65 years of age, it can be dangerous. Why? Because when a person acquires VZV infection in the earlier childhood, then automatically he becomes 100% immune, almost 100% immune to recurrent attacks of chickenpox. He may have zoster, but VZV attacking older people is always dangerous. It is theoretically and literature-wise supported. On that aspect, if at all somebody has never been exposed to chickenpox in his life, and if he is getting this infection for the first time after 65 years, or he is in a risk of getting this infection after 65 years of age, then it is always advisable to support him by giving proper proper kind of vaccination. So for this question, the best answer would be HPV more than that of hepatitis. And hepatitis B virus vaccination, do you remember? It is given in the form of 016 dosage for children or people who are going for medical college seats. First MBBS students will be asked to take, right? All these things to be remembered. Now, which is not a live vaccine? Here you have to understand hepatitis B virus is not even carrying a microbe. It is not just a live or a killed microbe. It contains a portion of the microbe which is referred to as subunit vaccine. It is referred to as subunit vaccine. On that aspect, the remaining options are definitely live vaccines. Here you will be able to have attenuated live microbes. Attenuated live microbes. In fact, MMR vaccine is a live vaccine, right? So measles, mumps, rubella, all three vaccines are definitely live vaccines. Now, let's look at the other vaccines that you have to know for the exams. When I start with the non-live vaccines, the first thing to be taken should be inactivated. Examples of inactivated vaccine or killed vaccine. Who are the best examples? Come on, tell me. Yes, the first one would be polio IPV, injectable form of polio vaccine. Next one is hepatitis A. You can also have rabies vaccine, which can be killed. Apart from that, you can go for other subunit vaccines. As you saw in case of hepatitis B, you can have recombinant or polysaccharide conjugated vaccines. And the best examples can be, as I said, HBV. You can take into consideration HPV. Then you can say HIB, which is Haemophilus influenzae type B vaccine. Apart from that, you can have pneumococcal vaccine. You can also have meningococcal vaccine. You have to remember the pneumococcal and meningococcal are polysaccharide vaccines which are conjugated. Why polysaccharides? Because in case of pneumococcus and meningococcus, what is common? Both of them are capsulated bacteria. It means capsule is the most terrific or the terrifying kind of antigen present on the surface of the organism. It is the most important virulence factor for destroying the host. At this point of time, you have to defend yourself against the capsule by giving antigens of the capsule well ahead of the real-time infection. So if a patient has been given the vaccine from the capsule is definitely made up of polysaccharides in case of both pneumococcus and meningococcus. But polysaccharide is a carbohydrate which is a very weak antigen, because of which you have to support the weak antigen by conjugating it with a better antigen. So it means an immunogen has been attached or an adjuvant has been attached. So pneumococcal and meningococcal are having a portion of the organism in the form of capsule which has been conjugated. And Haemophilus influenzae type B also follows the same protocol. It is also carrying a polysaccharide vaccine. Now look at the other things. You can also have toxoid vaccines, which is also not a live vaccine. It means you have taken an exotoxin and you have either heat treated it or chemical treated it so that the toxin component has been destroyed while the antigen component is retained, which is referred to as toxoid. Remember, only exotoxins can act as toxoids. You cannot toxoid an endotoxin because endotoxin is a lipopolysaccharide which is a very weak antigen on its own. On that aspect, you can have diphtheria toxoid, tetanus toxoid, as examples of attenuated toxins of these two organisms. Okay, next you can also have mRNA or viral vector vaccines, which are also not live vaccines. Example, both can be for COVID-19. In COVID-19, you can have mRNA vaccine also, and you can have viral vector RNA vaccine also. And in case of the COVID-19 mRNA vaccine, the best example can be from Pfizer, and in case of viral vector vaccines, it can be from Johnson & Johnson. So these are the other forms of the non-live vaccines that you have to remember. Now, who are the live vaccines? As I told you, MMR is a live vaccine. Apart from that, varicella is also a live vaccine. Yellow fever virus is also a live vaccine. Plus, rotavirus vaccine is also a live vaccine. I hope this will be helpful for all the future questions based on the infections and vaccination protocols. Okay, now let's look at the next question. Which BMW bag does pus swab that comes to microbiology lab go to? What is BMW? It is biomedical waste. So, when you want to go for biomedical waste bag into which a swab should be poured out, when enough amount of analysis is done, the answer should be yellow. Remember, yellow bags or category is designated for what? It is meant for infectious waste. Point number one, it is meant for infectious waste. That can include swab, tissues, or even if it's an instrument that is contaminated. Now, if an instrument is contaminated or some materials are contaminated, it may require incineration because they are infected already, and they require minimum of high level disinfection. So any kind of waste material that comes to the lab which requires high level disinfection and above should go to the yellow bag category. Now what about the remaining bags? See, red is meant for tubings, IV sets, which can be also contaminated. The ones which are contaminated and can go for incineration or high-level disinfection will go to yellow category of bags. While if there is a tubing with IV sets and contamination, then you can go for red-colored bags. And this will require autoclaving or microwaving before disposal. And what about black? Black is the easiest. It is known to contain non-hazardous waste. Deeper understanding of this question will be discussed in case of PSM, Preventive and Social Medicine. So this is for your current understanding. The answer for this question will be yellow bags, where the bag from the pus swab which will have to go for incineration or at least high level disinfection. Let's go for the next question. Barefoot walking, which fungi can affect? Now, many of the students who came with this question gave us only one option, Madurella, because they thought that is the best option. Of course, whenever you know the answer to a particular question very well, then automatically your brain shuts out the remaining options. So it's good. But I would like you to actually focus more on the question called as barefoot walking. If it is a barefoot walking, it means no footwear. So no protection. Now, no protection means the leg or the foot is vulnerable to invasive pathogens or inoculated pathogens. What do you mean by this? Invasive means the organism by itself can drill a hole and enter into the body. Inoculation means an external force is drilling a hole, which can be a mechanical trauma, which can be either blunt or sharp trauma. After the trauma has been inflicted, through the opening the organism enters. The organism does not have its own invasive ability of creating a hole. So on that aspect, you can think of both invasive organisms and inoculated organisms. When you say fungi, think of any kind of fungi present in the soil. So, if you focus on soil saprophytes, they can definitely go for invasive protocol when a person is not wearing footwear. Now, at this point of time, invasive need not be the right word because soil saprophytes by themselves don't have invasive property. So, the better answer would be inoculation. How are they getting inoculated? How are they getting pushed into the foot? Because they don't wear footwear, and when they are walking in rough terrain, small, sharp stones can drill a hole, and because the stones are coming from the soil only, the soil will contain the saprophytic fungi. When the stone is able to create a hole, through that particular stone, these fungi can enter inside. On that basis, you have to know who are the soil saprophytic fungi. Let me give you a list. One is Madurella madure, which is the one that you see in this question paper. Then Cladosporium, Fialophora, Fonseca. Very common organisms who are capable of entering after inoculation using minor trauma, and they are known for causing mycetoma. But mycetoma is not the only kind of fungal infection that can happen in barefoot. You can also expect chromoblastomycosis. Chromoblastomycosis is also caused by copper-colored soil saprophytes. Again, we can mention the 4 organisms which I have told you previously, but Madurella madure is known for causing Maduromystoma. Apart from that, you can also take into consideration this Cladosporium, Fialophora and Fonseca to be organisms known for causing chromoblastomycosis. So chromoblastomycosis and mycetoma, both of them are subcutaneous mycosis. So the most important thing I have taught you in the classroom about subcutaneous mycosis is that subcutaneous mycosis requires a prior mechanical trauma, which can either be a sharp trauma or a blunt trauma, and that can happen generally in case of absence of footwear. One other organism that we have to know in case of subcutaneous mycosis, which is very famous in the last 6 to 7 years of NEET PG and INI-CET exams, is Sporotrichosis. And you know what is the point to remember about Sporotrichosis? Yes, you speak about the rose thorn, which is pricking a human being. So the thorn is capable of pricking a human being and creating a sharp traumatic entry wound through which the spores of Sporotrich can enter inside and they can cause Sporotrichosis. So subcutaneous mycosis requires a prior trauma. In this question, they have asked you about barefoot walking. It tells you about the exposure of a human being to either invasive fungi or inoculated fungi. So here we are focusing on inoculated fungi more than that of invasive fungi. And if at all they ask you questions about parasites also, then whenever you think about filariform larvae, which have a sharp projection compared to that of rhabditiform larvae, filariform larvae of nematodes are capable of entering through the skin. Now let me write an example here. When it comes to parasites, filariform larvae are capable of penetrating the skin. Examples: hookworm, Necator americanus and Ankylostoma duodenale, and Strongyloides. Also, you can look at schistosomes, which are invasive through the skin using Meracidium, and they are capable of going through Cercariae. Meracidium will actually enter into a primary and a secondary kind of host. In case of schistosomiasis, you will be having 2 hosts, one being human being, the definitive host, and the other being a snail, which is an intermediate host. So when a human being is releasing the eggs will release some kind of meracidia. The meracidia will travel into a snail, and in the snail, which is also a host, which is intermediate host, where one larva becomes another larva called as Cercariae. Cercariae is liberated from the snail. The Cercariae will be floating in the water, and the Cercariae will come and attack the skin, through which the Cercariae can enter into the blood vessels, and there they develop into adults. So in case of no footwear, please be focused on the filariform larvae infection by hookworm and that of Strongyloides, where there is invasiveness. The same in case of Schistosoma hematobium, Schistosoma manzoni, and Schistosoma japonicum, where again the Cercariae is capable of penetrating. When it comes to fungi, invasive fungi are very less in numbers. Only inoculated fungi are taken into consideration. Now let's look at the next question. Now, which is a method for antibiotic sensitivity? Now, when you come for antibiotic sensitivity, this E-test is referred to as the epsilometer test, which is capable of helping you understand the antimicrobial resistance or sensitivity. Yellex gel precipitation identifies the presence of free toxin. In which organism? In case of Corynebacterium diphtheriae. What does the presence of free toxin tell you? If the toxin is freely available in the blood, then the toxin is capable of causing a full-blown disease called as diphtheria. If a person is vaccinated, the vaccination induces the formation of antibodies. Those antibodies will act as antitoxins and they will go and block the free toxins. So when a person is vaccinated, even though he is exposed to C. diphtheriae, he will not have free toxins because the antibodies will have blocked them. So he will have a negative LX gel precipitation test. So whenever LX gel precipitation test is positive, it indicates the presence of a free toxin that indicates susceptibility of the patient to diphtheria. CAMP reaction. This reaction is used to identify group B Streptococcus. Streptococcus group B Egalaxiae. Arrowhead formation can be noticed. Try to recollect what we have learnt about CAMP reaction in our videos. Go back and find out which other organisms can have a CAMP reaction positive. What is reverse CAMP reaction? What is the full form of CAMP reaction? They are not supposed to write it as small CAMP. It is capital CAMP. It is Christie, Atkins, Munch, Peterson. Latex agglutination test is capable of making an identification or the presence of antibodies based on clumping using latex beads. It can be useful in many kinds of infections and the diagnosis, example even case of cryptococcus. Now epsilometer test creates a ellipsoidal content. If at all you look at proper measurement of minimum inhibitory concentration, that proper measurement can be done by epsilometer. It is far more accurate than that of lawn culture technique or the technique where you go for the whole slide and expect the clearing of the organism and their infections. So remember, this epsilometer test is capable of identifying exactly where this happens or how much is the concentration of drug against which the resistance is beginning. Now look at this. When the bacteria grow, the antibiotic diffuses out from the strip. You will be having a strip here. Antibiotic diffuses from the strip. This diffusion will cause gradient of antibiotic concentration. Now when you go for a proper incubation, the incubation will cause clear elliptical zone around the strip where the bacterial growth is blocked. Now the strip will be given proper graduation. You will know for every single line that describes a concentration of the antibiotic. So it can be like this, the clearance can be like this, the clearance can be like this, the clearance can be like this, depending upon up to which concentration the drug has been effective and up to which dilution the drug has been effective. So remember, when that point has been seen where the edge of the zone intersects, the strip indicates the MIC. If for example I say this is the point where the clearance has been blocked, beyond which the clearance is not effective, then this would be the concentration of the drug or the dilution of the drug beyond which you will not be able to block the growth of the drug. Now, growth of the bacteria. Now, what are the advantages? It is more precise measurement than other standard disc diffusion methods. But the question that I expect in the next exam is that it is very useful for testing fastidious organisms and to identify their complex antibiotic resistance patterns. I would like you to take a note of this information so that it can be useful in the upcoming exams if there is a repetition or a modified repetition of the same question. What is a fastidious organism? An organism who has exacting growth requirements. So if you can offer special kind of nutrients because that organism requires that exact nutrient compared to any other organism, then offering that kind of exact nutrition makes the medium as a enriched medium and the organism as fastidious organism. To understand the activity of a fastidious organism and its complex resistance patterns, you will be using epsilometer test. So remember, in epsilometer test or E test, you will be having a strip and the strip will be mildly graduated. The graduation tells you the different concentration or the dilution of the drug. So beyond which you will be able to identify exactly at this concentration the drug is ineffective. Up to that concentration the drug is effective. All these things can be seen. Now let's look at the next question. This question has been done and dusted so many times. It has been the 9th time since it has been asked. We have discussed all the previous questions in our videos. Mark my words, all these questions have been discussed and the questions have been very simple in the question paper. We have discussed more complex things in our videos also. So make sure you go back and revise the videos as much as possible and look at the notes so that it can be helpful if you don't have enough time for the videos. Now look at this question, a gardener for Himachal Pradesh. Now I have given you some key words. When they say gardener or when they say honeymoon couple, and if they say they are dealing with rose gardens, if the honeymoon couple is going to a rose garden, and when Himachal Pradesh is mentioned, the rose gardens will make sure that there can be thorns on the rose, and when the thorn is pricking, it is creating an inoculation. So inoculation and entry of a fungus into the skin will be referred to as subcutaneous mycosis, right? So subcutaneous mycosis, the answer would be sporotrichosis. Now what about mycetoma and actinomycetes? You don't have to go for Himachal Pradesh or gardener. If at all they speak about absence of footwear, then it is definitely either mycetoma caused by fungi or mycetoma caused by bacteria. When you speak about histoplasmosis, it is acquired by inhalation. And what are the other questions that we have to know? See, when the organism enters into the body because of the thorn prick, the spores have been deposited inside. And the spores will give the organism out. The fungi will try to travel towards the lymphatics. So fungi are lympho-invasive. And in the lymphatics, they keep on growing and they keep on traveling slowly, very slowly. And whenever they are eating the triglycerides present in the lymphatics, they become fat. And when they become so fat enough to block the lymphatic, at that point of time, they will erupt outside the skin. That is why you have painful ulceronodular eruptions, and these lesions will actually release some of the fungi out into the skin, and the remaining fungi again will start traveling up the lymphatics. Again they'll try to become fat. So along the line of lymphatics, if you find these eruptions after being pricked by a thorn, in case of Himachal Pradesh, think of sporotrichosis. And the treatment can be surgical debridement and potassium iodide instillation, and the antifungal drug is itraconazole. Itraconazole is the drug of choice in case of sporotrichosis. And which kind of lymph nodes will be involved in case of your subcutaneous mycosis? The route of entry should be known. If the entry has been through the foot, then you will be looking at inguinal lymphadenopathy. Because it is coming from the hands, it can be going for axillary lymphadenopathy. And the organism was realized under lactophenol cotton blue. The picture was given, but the picture is not known exactly. Okay, now let's look at the question number 8. What is passive immunity? The passive immunity means no activation of the host immune response. No activation of host immune response. And this passive immunity can be natural or it can be acquired. The best example of natural passive immunity is transfer of antibodies from mother to the fetus. So antibodies have been given to the fetus, but the fetus has not been exposed to the antigen. Because the fetus is not getting the antigen, the fetal immune response has not been activated. So the antibodies from the mother will come and help the fetus and disappear after the work is done. Now what is acquired passive immunity? By giving hyperimmune serum. What is the meaning of hyperimmune serum? See, you pick up a rabbit or a horse. Most commonly, if you give it to a horse, you give the antigen to the horse. Now the antigen will produce a lot of antibodies, and those antibody numbers will be extremely huge compared to the number of antibodies that can be ever produced in the human being. That is why you call it as hyperimmune serum. And now you take the antibodies called as immunoglobulins and give it to the human being. Now the best example of this can be anti-tetanus serum. Example, antitoxin. Antitoxin is nothing but antibody. So this is a passive immunity. But what is toxoid? We have already discussed. Toxoid means you pick up an exotoxin and destroy the toxic property and retain the antigenic property. Now when it is given to a human being, the antigen goes and triggers your immune response. So toxoid becomes a type of vaccination, and all vaccinations are technically active immunity. Done. Simple. Next, which can be prevented by vaccination? Now, what is HCC? If you look at HCC as hepatocellular carcinoma, and you take cervical cancer, both are practically prevented by vaccination. See, cervical cancer is very common in females who have multiple sexual partners and initiated sexual activity at a very young age. HPV has multiple strains. The lower the number, the lesser the danger of the HPV infection. For example, if I say 1 and 2, or if you think at 1, 3 and 4, they are capable of causing very common warts. If you look at 6 and 8, you will be able to see anogenital warts. But when you go for 16, then if you go at 18, they are capable of causing cancer cervix. So, giving a HPV vaccine is capable of preventing cervical cancer efficiently. And this was the first vaccine-preventable cancer that came into understanding. Now, what about hepatocellular carcinoma? Hepatitis C is more capable of causing hepatocellular carcinoma than that of hepatitis B, while hepatitis B viral vaccine, if at all you go for a subunit vaccine, it is also capable of preventing hepatocellular carcinoma. So in this question, option D is a better answer than that of option A, but both of them are right answers. When it comes to Burkitt's lymphoma, it is very commonly seen as atypical lymphocytes being formed after a person who has been infected by Epstein-Barr virus. EBV vaccination is not very widely used, and the vaccination has not been effective in case of preventing Burkitt's lymphoma also. So EBV, which is capable of causing transforming growth. It is a transforming virus. What is a transforming virus? When a virus enters into a normal cell and activates your tumor activating oncogenes and inhibit the tumor suppressor genes, they are converting a normal cell into a tumor cell. So that is called as a transforming virus. EBV is a classical transforming virus who will convert a normal B lymphocyte into an atypical B lymphocyte and can cause B cell lymphoma. But EBV cannot be prevented by vaccination. Now, what is about Merkel cell carcinoma? We'll just add one information to this. See, MCC or Merkel cell cancer is a Merkel cell polyoma viral infection. It is caused by Merkel cell polyoma viral infection, and this happens with other factors as UV radiation exposure. It can be by immunosuppression or in case of older age. These are the risk factors for Merkel cell carcinoma. And this Merkel cell cancer appears as a painless, firm, rapidly growing nodule. And where, because I said UV radiation exposure, right, it means in the sun exposed areas. And you don't have a vaccine for the polyoma virus, so you can't prevent the Merkel cell carcinoma. And where does it happen? It happens or originates in the Merkel cells in the skin, located in the outer layer of skin called as epidermis. And remember, if at all you look at aggressiveness, it is known for fast growth. and it has a potential for spreading locally and systemically. It can go to the lymph nodes and the local organs. These are the things that you have to know about Merkel cell carcinoma when it comes to polyoma viral infection, which is not vaccine preventable. Okay, a 2-year-old child with watery diarrhea and dehydration. What is the most common cause? See, whenever you look at children, this is a straightforward question, no confusion at all about it. It is rotavirus belonging to Reoviridae. And remember, if at all it is a viral watery diarrhea, in case of adults, it would be Norwalk virus. You can also take into consideration Calliciviridae. And if it is for children, always think of rotavirus. Rotaviral diarrhea is the most common cause of traveler's viral diarrhea in case of children. What about Shigella? Shigella is a horrible organism capable of causing dysentery. Mostly it cannot be watery, it will be bloody. And Trichuris is capable of causing rectal prolapse along with diarrhea, while Yersinia is capable of causing bloody diarrhea, but it does not actually localize only to the children. It can be for anybody who is going through food poisoning. Which organism it is? Not all forms of Yersinia. It is Yersinia enterocolitica. Because 2-year-old children, rotavirus is very commonly known to cause diarrhea. Consistent watery diarrhea or persistent watery diarrhea is known for causing dehydration only in terms of rotaviral infections. Child with hematuria and thrombocytopenia. Now this question can be confusing. Why? Because you have E. coli O157H7 and Shigella, both of them being very good causes of hemolytic uremic syndrome. Hemolytic uremic syndrome. Now there is a question. What is the most common cause of HUS? The most common cause of HUS globally is Shigella dysentery type 1. The most common cause of HUS in India, again, is Shigella dysentery type 1. Now, HUS in case of developed countries, UK, USA, and that of European countries is enterohemorrhagic E. coli O157H7. And if they add ground beef, that is the beef that has gone for grinding, and if the area where the grinding happens is contaminated, it can easily spread this organism called as EHEC. Now for this question, when you speak about hematuria and thrombocytopenia, why am I speaking about HUS? Because HUS is hemolytic uremic syndrome, right? You will be expecting uremia where the kidney is involved. It can lead to pre-renal failure. If that pre-renal failure is not treated at the right time, it may progress to renal failure also. And when you speak about hemolytic uremic syndrome, thrombocytopenia is a very important concept. And when hemolysis happens, hematuria can happen. So, hematuria and thrombocytopenia is a property of hemolytic uremic syndrome, which can be caused by both Shigella and E. coli. Many people can give you different answers. Because HUS is very common in the world and in India, I will choose Shigella to be the answer. But if they speak about children more specifically, and if they focus mostly on children and they don't concern themselves with the locality, then you can go for E. coli O157H7 also. Now look at this. What is the drug of choice for fasciola hepatica? What do you think is the answer? See, the answer would be triclobendazole. Triclobendazole is the current drug of choice in case of fasciola hepatica, and you have to know it for the future references also. Here, the point of concern is albendazole, mebendazole has been helpful for other kinds of nematodes, and sometimes it can be helpful in case of some flukes also. Praziquantel is capable of causing spastic paralysis of your organisms so that faster clearance on the GIT can happen. But triclobendazole is most commonly the drug of choice in case of fasciola hepatica. Fasciola hepatica is referred to as liver fluke. And this liver fluke is capable of causing hepatocellular carcinoma. And there is one more liver fluke, which is also referred to as hepatobiliary fluke, called as Clonorchis sinensis, oriental liver fluke. And this is known for causing hepatobiliary carcinoma, cholangiocarcinoma. So Fasciella hepatica is also a liver fluke. Clonorchis sinensis is also a fluke. In this fluke, the drug of choice is triclobendazole. Okay, sterilization method done for inoculation loop, the loop that is used for creating a bacterial inoculation. It is placing over the heat until the red heat happens. It is a very simple method because of which you will be able to destroy most of the bacteria. The bacteria will not go for contamination. And why we are speaking about this? Because bacterial inoculation means you're trying to use a wire where some amount of strains of an organism can be taken to the specimen and you're trying to streak it on the culture plate. So you do not want other bacteria to cause contamination. It is not life-threatening condition, so you don't have to go for high grade or high level disinfection. A simple moderate disinfection like sterilization using placing over the red heat on a flame is enough. Who is at the highest risk of spread of HIV/AIDS? This is a very confusing question. Many students think that when a person is having a female sexual activity or the person is a female sexual worker, then they are at high risk. Or they speak about long distance truck drivers, they are at high risk. The point here is the efficiency of spread. Efficiency of spread is always high in case of intravenous drug abuse or by blood transfusion. There is a very high percentage of transfer. It is almost 70 to 80% spread if it is blood-borne transfusion. If it is a needle prick, it comes down dramatically to less than 2%. And when it comes to sexual activity, the risk is even lesser. But the problem is the whole world knows about unprotected sexual intercourse as the most important way of spreading of HIV/AIDS because it is the most common method. Not every day a human being will be undergoing blood transfusion. Not every day a normal human being will be in a hospital undergoing needle prick or needle prick injuries. In case of medical personnel, when needle prick injury is very common, it can become common and also efficient. But normally, blood transfusion is the best way and the efficient way of spreading infection. Here, intravenous drug abuse means if a viral infection is present in the needle, the spread into the blood vessel is extremely high. So this is at the highest risk. Female sexual workers are lesser at risk compared to men having sexual intercourse with men. Why? Because whenever there is a sodomous activity, the sodomy will cause injury in the rectal area. And when there is injury in the rectal area, there is opening of the mucosa and the blood vessels, which will be open to accept more amount of viruses. And whenever you go for long distance truck drivers, the truck drivers will mostly have unprotected sexual intercourse according to the literature being provided, because of which they're also at risk. So if you go for the order, you have long distance truck drivers and men having sexual intercourse with men having equal risk and female sexual workers having lesser risk, but intravenous drug abuse having the highest risk. When you speak about branched filamentous bacteria, now if this picture is given and they say it is an acid-fast organism because it is pink in color, then the answer of choice is Nocardia brasiliensis or Nocardia asteroidis. If they say it is non-acid-fast, then the answer would be Actinomycetes and Actinobacillus. This is one of the differences between Nocardia and Actinomycetes. The other difference is Nocardia is strictly aerobic and Actinomycetes is strictly anaerobic. And Nocardia is a filamentous bacteria. Actinomycetes is also a filamentous bacteria, while Nocardia is acid-fast, partially acid-fast up to 1% sulfuric acid or 1% acetic acid. Actinomycetes is absolutely non-acid-fast. When it comes to Listeria, they are rods, proper rods. They are non-filamentous, which can exhibit tumbling motility at 25 degrees Celsius. Trypanosomes are not bacteria. Trypanosomes are protozoa. If at all you mean to say Treponema, then Treponema are bacteria, but they are not filamentous bacteria. They are spirochetal bacteria. While Staphylococcus is a gram-positive bacterium, it does not even come into the concept of bacilli to be called as filamentous. They are technically cocci. And what kind of cocci? They are clumps of cocci causing bunch of grapes appearance if it is aureus. So they are cocci in clusters. So the best answer would be nocardia. Adults with hemorrhagic diarrhea. If at all you speak about adults with hemorrhagic diarrhea, the question paper, I am not very sure how it was, whether it was child with hemorrhagic diarrhea or adults with hemorrhagic diarrhea. In India, always go for Shigella. It is more common than that of EHEC O157H7. Salmonella is a very less common cause of hemorrhagic diarrhea. Okay, wire used in bacterial inoculation is sterilized using heat till red. The same question has been repeated, don't worry about it. All the following can amount to cold sterilization except, see, what is cold sterilization? Where there is no increase in temperature. On that aspect, remember, autoclaving by itself is a very high temperature. It can easily cross 100 degrees Celsius. The best way is to use it at 121 degrees Celsius for more than 1 minute or more than 12 minutes to 30 minutes. The temperature, if it is increasing, the duration of exposure decreases. So whatever happens, minimum temperature should be 121 degrees Celsius in case of autoclaving. Not just the temperature, also pressure should be increased in case of autoclaving. So once the temperature increases, it is no more cold. So the best answer for this question is autoclaving. Now, why do I speak about the remaining options? See, if you focus on photolaser, this is light amplified stimulated emission of radiation. So this laser can actually be based on light, but it does not increase the temperature. This does not increase the temperature. And this is useful in case of some medical and lab applications. The other thing you know automatically, what is cryo? Cryo means you're using extremely low temperatures. And you can sterilize or you can try to preserve. Both can be done. Sterilization of an instrument so that other organisms can be cleared or some tissue can be preserved, and this can qualify as cold sterilization. What about gas plasma? This uses low temperature plasma. What is plasma? Highly ionized state. So this also can come under cold sterilization. The only one that does not come under cold sterilization is gas plasma. Okay, which of the following is a topical antifungal administered for onychomycosis? The best answer would be ketoconazole. Ketoconazole is given topically and also it can be given enterally or orally. This can be either a systemic drug or it can be a locally applied drug, while terbinafine is given as a systemically given drug. Terbinafine can be given systemically in conditions. Sometimes it can be available in the topical form also. But the best drug in case of topical antifungal, in case of onychomycosis, automatically comes towards ketoconazole. Now, who is the most commonly used topical antifungal agent? The answer would be clotrimazole. For future questions, the most commonly used topical antifungal. This is given in case of athlete's foot or ringworm infestations. Now, apart from this, terbinafine and miconazole can be given as topical forms. But itraconazole is given in the form of systemic version. Oral itraconazole can be tried. Terbinafine can be given sometimes systemically, mostly topically, but it is not very effective in case of onychomycosis. The best answer for this question would be ketoconazole. These are triazoles. capable of attacking the cell membrane and by blocking ergosterol synthesis. Culture medium for Mycobacterium tuberculosis is a dead easy question. The answer is Lowenstein-Jensen medium, which takes approximately 3 weeks for the culture to become positive, because MTB, unlike other bacteria, does not grow very rapidly. Binary fission does not happen in rapid phases, so it takes 3 weeks for the doubling of the organism to happen so that it can be seen on the culture media. And MTB is the fastest among the other kinds of mycobacteria. For example, M. leprae has an incubation period of 3 years to 5 years. There are also something called as rapid growers in mycobacteria, and there are slow growers in mycobacteria also, but MTB is capable of showing a moderate number, which is an acceptable number, called as 3 weeks. Lowenstein-Jensen media. What are the other media? Dorset's egg media, Middlebrook media, Dubois media, Waterhouse media are all different media in case of tuberculosis. Please check the videos of this particular culture media to have a better understanding. Also, Bactec agar can be used. Automated methods can be used to grow the organism, and you will be able to identify even proper kinds of mutations using the advanced techniques. Blood agar can be used for any kind of bacteria, which is a typical bacteria, while Mycobacterium tuberculosis and organisms which appear after Mycobacterium in your bacteriology are technically atypical. SDA Sabaros dextrose agar, which is meant for fungi. Blood agar is generally for typical bacteria. SDA is for fungi. Buffered charcoal yeast extract is for Legionella. Test used in the field of malaria. Now, I'm not very sure about how this question has been framed. If they say which one is not diagnostic in case of malaria, which one is not helpful for diagnosis of malaria, again the question can be confusing. So, HRP is histidine-rich protein 2. This HRP2 is definitely used in diagnosis and has been the antigen-based testing. Thick film is important for identifying plasmodia and their presence. While thin film is important for species differentiation. And quantitative buffer coat obviously has been useful in case of diagnosis of malaria. So when they ask you which one is not a diagnostic test, I may choose thin film, because thin film is not meant for diagnosis, it is meant for identifying the species in the organism, while thick film has been commonly used in case of malaria. So thin film is not a diagnostic test, but definitely it can help in diagnosis. As far as this question believes, I would say none of the above is the right answer. So all of them are involved. HRP2 is antigen based. What is exclusive waterborne hepatitis virus? See, fecal-oral route is for hepatitis A and hepatitis E. In that aspect, hepatitis A should be the answer of choice, while hepatitis B, C and D happen in a closed atmosphere, which can either be blood-borne transfusion or it can be by needle prick, it can be iatrogenic, or it can even be because of sexual transmission. And less than 1% people with hepatitis A can go for fulminant hepatitis and die. And fulminant hepatitis becomes very common in hepatitis E if at all the patient is a pregnant female. Look at the question here. A 20-year-old boy with skin abscess progressing to necrotizing fasciitis. Pus on examination revealed gram-positive cocci in chains. If it is a gram-positive cocci in chains, there is nothing you have to worry about. It automatically comes under streptococci. Now, if it is streptococci, then the most common streptococci known to attack skin of a 20-year-old male, that is 20 years, is about the best of the physiological response. You have good amount of immunity. If it is less than 3 years or more than 65 years, any organism can become dangerous because of the vulnerability of the population. But this person is not highly vulnerable. It means it takes a very virulent organism like Streptococcus pyogenes, which is group A. Staphylococcus aureus is even more common than streptococcus in causing a similar condition. But the point is, you have seen gram-positive cocci in chains and not in clusters. If at all it was gram-positive cocci in clusters, it becomes Staphylococcus aureus. And remember, in case of Streptococcus pyogenes, you go for Lansfield's classification, where you go for grouping from A to V, except I and J. There is no I, there is no J, and group A is the most virulent, and the group A grouping is done based on the C carbohydrate antigen. Under the group A, you go for typing. Typing is based on M protein, and M protein based typing of group A gives you M1 to M80, out of which M1, M2, M3 are known to be called as flesh-eating bacteria. We have discussed all these things in our classrooms. Go back and revise it whenever you have time. When they say flesh-eating bacteria, they're capable of reaching necrotizing fasciitis very rapidly. So surgical debridement and local installation of antibiotics is the drug of choice. Enterococcus faecalis is not known for causing skin infection, just like that of micrococcus. Not effective against COVID-19. See, this is a very unique question. Many people will have patchy kind of memory from that of the COVID-19 period. Remember one thing, during the COVID-19 period, ivermectin was promoted as an anti-COVID drug, but there were many large-scale trials. I repeat, large-scale trials, systemic review of many studies after meta-analysis have proven that this ivermectin does not provide any meaningful benefit. This is what they have said. And they have also mentioned not to use ivermectin except in case of clinical trials. So why are we not using? Because there is lack of evidence where it is beneficial. Second thing is, it may also be having a toxic potential. It has less amount of safety protocols available, and you have better alternatives. The better alternatives to ivermectin could be remdesivir and Paxlovid. Even hydroxychloroquine was used with some amount of benefit, but ivermectin has been proven to be of no benefit. And you obviously know mask is one of the most important effective methods, where mask, if it is worn by the patient who has COVID-19, that prevents 95% of transmission to other people. So when we wear mask in case of SARS-CoV-2 or COVID-19, we are protecting others more than ourselves. That is important. Second thing, vaccine has been proven to be very effective, with the first dose giving us 60% protection, second dose reaching up to 90% protection in most of the vaccines have been shown. So COVID-19, ivermectin has not been effective. Now look at this question. Diabetic patient with pleural effusion, tree in bud appearance on the CT scan, hilar lymphadenopathy is present, low ADA levels. Now many times people will easily jump to the answer called as tuberculosis, because they see ADA levels being mentioned. Now pleural fluid is the specimen that has been tested for ADA. What is ADA? Adenosine deaminase, which is the enzyme that is capable of causing deamination of adenosine. So when this enzyme is not available, adenosine levels will keep on increasing. When the adenosine levels are increasing, they become toxic to the lymphocytes, like T lymphocytes, and they may kill the T lymphocytes or render them ineffective. So this may lead to severe combined immunodeficiency. Why combined immunodeficiency? Because the T4 lymphocytes are the ultimate masters of the whole immune response. When those CD4 cells are killed by the excess amount of adenosine, then the CMI fails. When the CMI is failing, activation of humoral immunity, conversion of B lymphocytes into plasma cells also fails through T helper type 2 failure. So severe combined immunodeficiency can be noticed. If there is a skid, many infections can become dangerous for the human being. So fungi may be actually seen, but the reactive lymphocytes are less. Anthracotic pigment is what you see as a part of your occupational hazard. Necrotizing granuloma indicates tuberculosis. necrotizing granuloma indicates tuberculosis. If tuberculosis was the reason for the pleural effusion, ADA levels will be elevated. Please make a note of this. ADA levels will be elevated. So at this point of time, when there is a skid, fungal infection may actually be noticed. Because they are mentioning hyphae and not spores, it is not just an entry of a fungus. The fungus has already been inside the human body and they are surrounded by the lymphocytes. So the lymphocytes are trying to fight the fungal hyphae, but they are not able to fight efficiently. That is why fungal infections can be dangerous. In the same question, if ADA levels were elevated, 100% I would say the answer can be tuberculosis. So remember the answer right now, because of diabetes, I can say it is fungal infection. I hope you will be able to use this in your exams. Okay, what is the most common cause of croup in children? Croup is caused by para-influenza virus, not by influenza virus, while the remaining organisms are not even related to croup in any way. So look at the explanation here. Para-influenza viruses are the most common cause of croup in children, accounting for more than 65% of cases. Para-influenza virus types 1 and 2 are responsible for the majority of croup cases and outbreaks. What is about para-influenza 3? This causes bronchiolitis and pneumonia in young children and infants. Now comes another question. Who is the most common cause of bronchiolitis in infants? The answer would be respiratory syncytial virus. What are the other causes of croup? It is influenza A and B, measles, adenovirus, respiratory syncytial virus, and mycoplasma pneumoniae. So here you understand, for croup, the next best answer should actually be a virus. That is influenza A and B, measles, adenovirus, respiratory syncytial virus, and then comes an atypical bacteria. Apart from that, croup is a seasonal illness. It affects children between the ages of 6 months and 3 years. The main symptom of croup is a barking cough. That kind of cough is about to show that a very weakling dog who has been injured with a stone, the same kind of bark can be noticed. And it starts suddenly at night. What are the other symptoms of croup? You can have runny nose, sore throat, congestion, mild fever. Noisy breathing stridor is a very important part, along with that of a rasping sound when breathing in. Mostly breathing in rather than breathing out. A hoarse throat. All these things point towards croup. So in this question, the best answer should be influenza A or B as the next common cause after that of para-influenza, but the best answer would always be para-influenza. A patient with hepatic cyst, what does the aspiration show? This is a very beautiful question. See, when you speak about hydatid disease, hydatid cysts will be very commonly seen. And the most common site of hydatid cyst would be liver, and then it can be in the lungs. In the lungs, they are capable of creating a proper water lily sign more than the liver infection or liver cyst. Now, apart from this, the hydatid cyst can happen elsewhere also, in the muscles, in the bone area, sometimes in the brain also it is possible, but liver is the most common site for the hydatid cyst formation. Now, why is this important? See, whenever you speak about cyst happening in case of the liver, you can also think of tinea solium, which causes a condition called as cysticercosis. Cysticercus cellulose. And this cysticercosis, if it attacks your brain, you call it as neurocysticercosis. Here, you will be able to see this tinea solium being affecting in causing neurocysticercosis when you have ingested the eggs also. It primarily affects the brain rather than that of liver, while Echinococcus granulosus affects liver than that of other organisms. So for this question, we can go for A better than B, but both A and B are capable of showing hepatic cyst. And tinea saginatum, even though it may cause cystic disease, it is very rare. It's a very rare organism in causing cysticercosis. So my safe understanding would be the answer as Echinococcus granulosus. Okay, which drug binds to CD4 and has action on CCR5? The point is, ibalizumab is also capable of inhibiting CD4, while maraviroc is also capable of attacking CD4. But remember, this maraviroc is technically a CCR5 antagonist. And this CCR5 antagonist is capable of preventing HIV from entering CD4 cells. Now, this ibalizumab and maraviroc can be confusing to the patients or the students also. Here the point is, ibalizumab is a monoclonal antibody. And it binds to the CD4 receptor extracellular domain. Now, when it binds to the extracellular domain of CD4, what does it do? It causes the blocking of conformational change required. Conformational change that is required on the CD4 cells so that for HIV to bind to the cell called as CD4. So ibalizumab can bind to the CD4's extracellular domain, but it will block the conformational change that is required on the CD4 domain so that it can be more acceptable and welcoming of HIV. While maraviroc is the one who is known to have a CC4 or CCR5 antagonistic property. This ibalizumab does not have. Ibalizumab does not directly act on CCR5 or CXCR4. Now, let's try to understand the role of CCR5 and CXCR. What is the concept here? See, CCR5 and CXCR4 are referred to as co-receptors. This is an important concept in case of HIV infection. Why HIV infection is for life? See, whenever you have the HIV being presented by the macrophage, the presentation will attach to the CD4 cells or the T4 receptor present on the surface of T4 cell. Now, if the present antigen or the processed antigen is placed in the groove between the alpha and the beta subunits of T4 receptor, it is a normal antigen presentation. It is like shaking hands with each other. But imagine if another hand comes from here, another hand comes from here, then the combination or the interaction and the engagement is more stronger. So, engagement is stronger because of a concept called as co-receptor. It can be similar to the B7 second signaling that you see in case of immunology. We have taught about this in detail in immunology section, so go back and see it. What I'm saying is, if a processed antigen is presented by the antigen presenting cell to the T4 cell, if it is given to the proper receptor, it is called as a primary presentation and engaging. But co-receptor engaging makes the engagement even more stronger. And in that area, CCR5 and CXCR4 will play a major role. Now, what happens is, this maraviroc targets CCR5 co-receptor, and it may block the receptor from going for a conformational change, which can be helpful for accepting HIV. Now, when the CCR5 is actually being blocked, then co-receptor function is blocked. So, the engagement becomes weaker. Now, this drug is effective in those strains which are using CCR5. So, which strains? They are referred to as R5 tropic strains. These are all important for your exams. Make a note of this. R5 tropic strains. Apart from that, you can also have understanding that maraviroc has no direct action on CXCR. No direct action CXCR4. But its role in inhibiting CCR5 prevents the virus from entering the cells, because of which, using this pathway, you will be able to go for CXCR or CCR5 blockage efficient. So let me repeat, maraviroc ability in case of HIV infection is by having an effect on the CCR5 more than that of CXCR4. When it comes to this ibalizumab. This drug is known to have an effect on CD4, which is the extracellular domain, and it blocks the conformational change that is available on the CD4 to accept the HIV, and it is not a direct kind of CCR5 antagonist. So I hope you will be able to use this information in the future. Whiff test is positive in. The answer is bacterial vaginosis. What is whiff test? When you add 10% KOH to the vaginal secretions, the KOH is a corrosive, and if the ammonia containing compounds are present, it can liberate ammonia. This ammonia will be liberated, offering a very pungent smell, which is unique in case of bacterial vaginosis. In case of candidiasis, there is no foul smell. In case of trichomoniasis, you don't have to worry about the ammonia release. Gonococcal urethritis does not smell much. So the best answer here would be bacterial vaginosis caused by Gardnerella vaginalis. We've already seen this organism infection already passed. Now, nasal swab used for testing for COVID-19 is discarded into yellow bin. I told you yellow bin is important for the infectious waste we send, and that infectious waste can go for incineration, right? If it is for autoclaving, what is the color? Yes, the right answer. Now look at match the following. All the answers have been given already in the right format, so it will be easier for you to remember it. Look at this. When you focus on the rabies as such, Negri body is the inclusion body you see in a live neuronal cell. And this can be found in hippocampus, subcortical neurons, Annen's horn, etc. And they are diagnostic of rabies in the post-mortem condition. For antemortem diagnosis, you can go for corneal smear for the virus. And in case of multiple myeloma, Dutcher cells are obviously seen. And these are characterized by intranuclear inclusion bodies. And where do you see this? We see them in the plasma cells. And you may actually mistake it for viral inclusion bodies, but they are technically myeloma's featured cell. Now comes a question. Students will ask me, so what is the difference between a viral inclusion body and a myeloma feature cell? See, an inclusion body is a simple logic. When a microbe enters into a macrophage or is swallowed by the macrophage, the microbe will be first placed inside a small vesicle, and that vesicle which has captured the microbe will be referred to as phagosome. Now, because a phagosome has formed, now the organism is stable inside the phagosome for a while. But meanwhile, you will be liberating a lot of depolarization signals which will activate the lysosome. So the lysosome will have the proton channel opened, protons will enter inside, lysosomes will become acidic. When they become acidic, the hydrolytic enzymes will be activated, and then activated lysosome will try to travel towards the phagosome. Phagosome will try to travel towards the lysosome. When both of them will fuse, they form a phagolysosome. And when the phagolysosome is formed, the membranes are dissolved, all the lytic enzymes will hit the microbe, and microbe will be destroyed into pieces. The macrophage wins, the microbe is destroyed. Now, if you are looking at an intracellular organism, then the intracellular organism is highly manipulative. It blocks any kind of information from moving from the phagosome to the lysosome, so lysosome is not activated. And even if the lysosome is activated, it is not allowed to come near the phagosome. Even if it comes near the phagosome, it will not be allowed to form a phagolysosome. So the phagosome is safe, the microbe is safe. So microbe wins, the organism is continuously replicating, the macrophage fails. Now either the macrophage is failing or the microbe is failing. But what if both of them are not failing and both of them are not succeeding? When both of them have reached a deadlock, that is, a microbe is not multiplying, at the same time microbe is not killed. The macrophage is not killed, and the macrophage is not allowing the organism to increase in number. So the organism becomes absolutely stable, it becomes dormant and does not do anything, and the organism has a special form of shape. Each organism will have its own special shape. It happens mostly in viruses and the atypical of microbes like chlamydia and rickettsia. So inclusion bodies are technically the viral particles which are not growing and not disturbing the macrophages. So Parkinson's Lewy body is nothing but an abnormal protein aggregate. Now comes a question. What does the Lewy body contain? Lewy body is known to contain alpha-synuclein. And where does it accumulate? It accumulates in the nerve cells. Which nerve cells? In the dopaminergic neurons. And this becomes the hallmark of Parkinson's disease. You can also have Lewy body dementia. So this is what I would want you to know. So we have discussed all the MCQs of microbiology and related questions towards infectious medicine as much as possible. So download this app and try to visualize as much information as possible. Watch all my videos and read the notes. It will be very helpful for the upcoming exams. All the very best.